There's a question that millions of men search for privately, but almost nobody asks a real doctor. What does frequent ejaculation actually do to the prostate? The answer matters more than most men realize. Because the prostate gland is not just a structure involved in sexual function, it is a gland that produces fluid, regulates urinary flow, and changes significantly with age. And the research on how ejaculation frequency interacts with prostate health is genuinely interesting and clinically important. Today, I want to give you the honest, complete, stigma-free clinical answer. What the science shows, what the mechanism actually is, what the limits of the research are, and one critical piece of information about ejaculation and prostate testing that most doctors never mention and that could affect your medical care directly. My name is Dr. Elizabeth Kavaler. I am a board-certified urologist and urogynecologist with over 20 years of clinical practice. The prostate gland sits directly within my clinical specialty, and I work with men experiencing prostate-related concerns every week. Everything I share today is based on published clinical research, including the studies most widely cited in urological medicine on this topic. Before we get to the research, here's the anatomy that makes this question clinically relevant. The prostate gland produces prostatic fluid, which makes up approximately 30% of semen volume. This fluid is stored in the glandular ducts of the prostate between ejaculations. When ejaculation occurs, the prostate contracts and expels this fluid through the urethra. The clinical hypothesis behind the ejaculation prostate cancer link is called the duct drainage hypothesis. It proposes that regular ejaculation flushes the prostatic ducts, removing accumulated cellular debris, carcinogenic secretions, and inflammatory byproducts that may, if left to accumulate over time, promote malignant cellular changes. Think of it as a drainage and clearance mechanism for a gland that continuously produces secretions. This is not proven causation. It is a biologically plausible mechanism that is supported by the epidemiological data. The distinction matters, and I will come back to it. The most cited study on this topic was published in the Journal of the American Medical Association in 2004, led by Leitzmann and colleagues. It followed nearly 30,000 men over 8 years and found that men who ejaculated 21 or more times per month had a significantly lower risk of prostate cancer compared to men who ejaculated 4 to 7 times per month. The reduction in risk was approximately 33% for high-frequency ejaculation. A follow-up analysis published in European Urology in 2016 by Ryder and colleagues replicated and extended these findings in the Health Professionals Follow-up Study, with over 31,000 participants followed for 18 years. Men with the highest ejaculation frequency, 21 or more times per month, had a 20% lower risk of prostate cancer overall and a more substantial risk reduction for lethal prostate cancer specifically. These are large, well-designed prospective studies. They are the strongest epidemiological evidence available on this question. Here's what they do not prove. They do not prove that ejaculation causes the reduced risk. They demonstrate an association. Men who ejaculate more frequently may also differ in other health behaviors: diet, physical activity, relationship status, healthcare engagement, that independently affect prostate cancer risk. Controlling for confounders in observational studies is imperfect. The duct drainage hypothesis is plausible, but not definitively established as the biological mechanism. What is clinically reasonable to say, based on this evidence, is that regular ejaculation is not harmful to the prostate and is associated with a meaningfully lower long-term prostate cancer risk. That is a clinically useful statement that most men have never heard clearly from a qualified source. 3 changes happen in the prostate as men age that are relevant to this discussion. First, benign prostatic hyperplasia, BPH. This is a non-cancerous enlargement of the prostate that affects the majority of men over 50 and the vast majority over 70. The enlarged prostate compresses the urethra, producing the urinary symptoms many men over 40 are already noticing: weaker stream, difficulty starting, frequent nighttime urination. Regular ejaculation does not reverse BPH, but it does support healthy prostatic fluid turnover and prevents the additional irritation that can come from fluid stagnation in an already enlarged gland. Second, dihydrotestosterone accumulation. DHT is a potent androgen produced from testosterone by the enzyme 5-alpha reductase inside the prostate. DHT drives both BPH and prostate cancer growth. Ejaculation does not reduce DHT levels, but it does reduce the local concentration of inflammatory mediators and cellular debris that DHT-driven proliferation depends on for promotion. The two processes are distinct but intersecting. Third, cellular risk accumulation. As prostate cells divide over decades, the cumulative risk of a replication error leading to a malignant cell increases. The duct drainage effect of regular ejaculation is thought to reduce the retention time of potential carcinogens in the ductal environment, which may reduce the probability of those cellular errors being initiated or promoted. Here's the clinical fact that almost no video on this topic mentions, and it is one of the most practically important things I can tell you. Ejaculation within 48 hours before a PSA test will artificially elevate your PSA reading. PSA, prostate-specific antigen, is the blood marker used to screen for prostate cancer. Normal prostatic activity, including ejaculation, temporarily increases PSA levels in the bloodstream. Studies have shown that ejaculation can elevate PSA by between 0.4 and 1.0 nanograms per milliliter in the 24 to 48 hours following. For a man whose baseline PSA is 3.5, that ejaculation-induced elevation could push his reading to 4.0 or above, crossing the threshold that typically triggers a biopsy referral. That biopsy carries real risks, including infection, bleeding, and significant anxiety. And the elevated PSA that caused it was not a cancer signal. It was a natural physiological response to ejaculation. The clinical guidance is straightforward. Do not ejaculate for at least 48 hours before any scheduled PSA blood test. If your doctor orders a PSA test, ask whether you need to abstain beforehand. Many doctors do not routinely give this instruction. Now you know to ask. Based on the clinical evidence, here is the practical guidance I would give any patient asking this question. A frequency of roughly 21 ejaculations per month, which is approximately 5 per week, is the frequency most consistently associated with the observed reduction in prostate cancer risk in the published literature. That does not mean less frequent ejaculation is harmful, and it does not mean you need to achieve that number artificially. The research reflects associations in natural behavior, not a clinical prescription. For prostate health broadly, the most evidence-supported protective behaviors are maintaining a healthy weight, regular aerobic exercise, a diet rich in tomatoes and cooked tomato products for lycopene content, and regular screening conversations with your doctor beginning at age 50 or 40 to 45 if you are Black or have a family history of prostate cancer. If you are already experiencing urinary symptoms, weaker stream, frequency, urgency, nocturia, book an appointment with a urologist. These symptoms have multiple possible causes and deserve clinical evaluation, not just a YouTube video. And before your next PSA test, abstain for 48 hours. That one piece of information alone may protect you from an unnecessary medical procedure. The silence around this topic does real harm. Men make uninformed decisions, worry unnecessarily, and sometimes avoid medical care because they do not have access to honest, clinical answers delivered without judgment. You came here with a real question. I hope you leave with a real answer. I am Dr. Elizabeth Kavaler. I will see you in the next video.